All right, coders, let's do this. Your exam is right around the corner, and we are going to do a rapid-fire review of one of the most common diagnoses you'll see, anemia. This is all about getting you prepped and ready to crack the code on this, so let's jump right in.
So here's our game plan. We're going to fly through 6 key areas. We'll start with the basics of what anemia actually is, then get into the really critical stuff, like acute versus chronic blood loss, dive into deficiency anemias, and untangle that tricky post-op anemia puzzle. We'll wrap it all up with the one golden rule you have to follow and the biggest mistakes to avoid.
First things first, before you even think about picking a code, you've got to understand the why. What is actually happening in the body? So let's start right at the beginning with the fundamental definition. At its heart, anemia is all about an imbalance. Just picture a scale. On one side, you have your body making new red blood cells. On the other, you have red blood cells being lost. When that scale gets tipped out of balance, that's anemia. Keep this simple idea in your head because it is the foundation for every single code we are about to cover.
Okay, let's get into what is probably the most common decision you're going to have to make when you see anemia in a chart. Is it from acute blood loss or is it chronic? And trust me, getting this distinction right is absolutely essential.
So look, D50.0 and D62, they tell two completely different stories. D50.0, that's your slow, steady leak over a long time. Think of a GI bleed that's been going on for months. But D62, that's a sudden major event, like a hemorrhage from a car accident. So D50.0 is about the long-term consequence of bleeding, while D62 is about the immediate result of a sudden loss of blood.
So how do you justify that D62 code? Well, you need 2 solid pieces of evidence in the documentation. First, the doctor has to explicitly state there was a sudden, significant loss of blood. And second, the labs have to back it up. You need to see a clear, sustained, and significant drop in the patient's hemoglobin or hematocrit. If you've got both of those, then yes, you can confidently assign D62.
Okay, quick knowledge check for you. The documentation says iron deficiency anemia, which makes your brain immediately think D50, right? But then it says it's secondary to acute blood loss. So what's the call? The answer is D62. That word acute is your main clue here. It's the driver. It points you directly to acute posthemorrhagic anemia, and it totally overrides the other descriptor.
Nice job on that. Now let's switch gears a bit. We're moving away from anemias caused by bleeding and into anemias that happen because the body is missing some essential building blocks, things like vitamins, minerals, or even specific enzymes.
So here's where the specific cause is everything. D50, that's all about iron. D51 is for vitamin B12 problems. D52, that's your folate deficiency. D53 is kind of a catch-all for other nutritional issues. And then D55 is a whole different beast. That's for anemias caused by genetic enzyme disorders. Each code tells a very specific story.
Now, I want you to really focus on this one because it's a favorite for exams. D52.1, Drug-induced folate deficiency anemia. If you see this documented, your job is not done after assigning that one code. There's a mandatory second step. Here's the full 4-step process. You have to do all of it.
First, you assign D52.1. Simple enough. Second, you find the drug that caused it. Third, you assign the correct T code for that drug. And fourth, and this is the step everyone forgets, you have to add a 6th character of 5 to that T code. That 5 tells the story that this was an adverse effect of a drug that was taken correctly.
Okay, time for a few rapid-fire practice runs. Let's see how you do. First up, the chart says, patient has anemia due to inadequate dietary iron intake. What code are you picking?
The correct answer here is D50.8, which is for other iron deficiency anemias. We use this specific code because the cause, inadequate diet, is clearly stated, making it more specific than the unspecified D50.9.
All right, scenario number 2. This time, the note says vitamin B12 deficiency anemia due to a lack of intrinsic factor. Which code category are we looking at now?
Yep, you got it. That puts us squarely in the D51 category. This is what's known as pernicious anemia. And you might be wondering, what is intrinsic factor? Well, it's a protein your stomach makes that is absolutely essential for absorbing B12 from your food. Without it, you could eat all the B12 in the world and it wouldn't matter. This code captures that specific problem. All right, let's move on to a really, really common source of confusion for coders, postoperative anemia. You know the drill. Patient has surgery, their blood count drops.
So, is that an expected outcome or is it a complication? The documentation is everything here. You need to burn these rules into your brain. A drop in hemoglobin after surgery does not automatically mean the patient has anemia that you can code. The physician must diagnose it and write anemia in the chart. If they do that but don't say why, your default code is D64.9, anemia unspecified. And you can only use D62 if the doctor specifically links that anemia to acute blood loss after the surgery. And that brings us to the single most important rule in all of coding, especially when the documentation is vague. And that rule is you don't guess, ever. Your job is to verify, and if you can't, you query the provider. So if you see the word anemia and nothing else, your work isn't done. It's just started. First, you become a detective. You dig through the whole chart. Labs, pathology, any notes from specialists. You're looking for clues. If you find something that points to a more specific cause, like a low B12 level, then you can query the doctor. But, and I can't stress this enough, you never, ever assign a specific diagnosis code based on a lab report alone. The doctor has to make the call.
We're almost there. We're in the home stretch now. Let's wrap up by locking in the biggest takeaways and pointing out the 3 most common mistakes coders make with anemia, so you can be sure to avoid them. Here they are, the top 3 pitfalls. Number 1. Assuming post-op blood loss is a complication. It's not, unless the doctor says so. Number 2, playing doctor and diagnosing from lab values. Don't do it. And number 3, forgetting that second T code with the 5 for drug-induced folate anemia. Avoid these 3 and you are well on your way.
Now, if you forget everything else from today, please remember this analogy. D50.0 chronic loss anemia, that's like a slow, leaky faucet. Just a little drip, drip, drip over a long, long time. But D62, acute loss anemia, that is a sudden burst pipe. It's a major catastrophic event. If you can picture that, it will help you make the right choice when you're under pressure. So what do you do when the chart just says anemia from blood loss, but gives you no clue if it was acute or chronic? Well, thankfully, the official guidelines give us the tiebreaker rule. When it's totally silent, you default to D50.0. That's a huge rule to remember. Let's end on one final thought to really cement this. If anemia is listed as the principal diagnosis, the main reason for the patient's visit, your job isn't just to code the anemia. Your first responsibility is to search that entire medical record for the underlying cause and sequence that cause first. That right there is the key to high-quality, accurate coding. Now go out there and ace that exam.